So even if you are not able to achieve the target dose, do we get the same benefit of ARNI? There are some patients who may have an intolerance for sacubitril and valsartan. There could be something like a worsening eGFR. There could be symptomatic hypotension. There could be hyperkalaemia or gastrointestinal symptoms. Now, sometimes we are unable to reach the target dose of 100 milligrams BID. It's okay. You can still keep the patient on a 50 milligram BID but keep the ARNI on board. Unless there's severe contraindication like severe hypotension, dizziness. But again, as I told you before, you should ensure that there is no hypotension because of dehydration and the overzealous use of diuretics. You will find that when you have guideline directed medical therapy of ARNI and SGLT2 inhibitors, MRA on board, beta blockers on board, the actual use of loop diuretics and other diuretics comes down. We should ensure that that's on a minimum dose. If the patient has reached his dry weight or her dry weight, ensure that the patient maintains a weight record. So if the patient was 70 kilos before he came to you, you started your treatment, the weight has come down to around 62 kilos, you have offloaded around 8 liters of water from the body, that is your dry weight. So maintain a weight record for your patients, see that they maintain a weight record, the fluid balance on a daily basis, and they report to you on a weekly or a bi-weekly basis. Now, the benefits irrespective of the dose. Now, participants can use a lower than target sacubitril valsartan dose, and 50 milligrams BID for some patients is adequate. There is no need for us to keep going to 100, 200 milligrams. Maybe the patient gets symptomatic during that 100 mg or 200 mg BID dose. Don't worry, but keep the patient on at least a 50 milligram BID dose. Now, is a new therapy like ARNI beneficial in HFrEF patients with borderline systolic blood pressure? Yes, of course. So when you look at these patients, the event rate of a patient not receiving ARNI is very, very high as compared to an ACE inhibitor. So if you compare head to head an ACE inhibitor and an ARNI, you will find that using an ARNI and the other three pillars of heart failure treatment, you are adding around 8 years of quality free, event free cardiovascular event free survival for these patients for a 55-year individual. So if you are able to even give a 50 milligram BID dose for these patients, I would say go for it. Now, there are certain episodes of hypotension which could occur in these patients, but very, very rarely do you have deaths due to hypotension because of ARNI. And how do we manage a patient who has hypotension with ARNI? The first thing is correct the volume or salt depletion prior to the administration of ARNI, and start sacubitril valsartan at the lower dose. In hypovolemia patients, the dose of diuretics is likely to be down titrated, especially when you are having a very, very higher dose of diuretics to start with. So we should start down titrating your diuretics as soon as possible. In fragile patients, elderly patients, start with ARNI at a lower dose because they will have a low systolic blood pressure of around 100. And in these patients, you should be very, very careful in starting an ARNI at a lower dose. And if a patient has got, is naive to ACE inhibitor or ARB, again start on a lower dose of ARNI or 50 milligram BID. Sometimes even 25 milligram BID can be started, and then up titrate slowly within a week or 2 weeks so that you're able to reach an achievable target. And then similar to the other dose, sometimes a maximal dose of ARNI like what we are targeting 100 mg, 200 mg may not be tolerable to all patients. So we don't need to achieve all that, but at least keep a 50 milligram or a tolerable dose of ARNI on board. Is this patient a candidate for ARNI? What can we do? Yes, in my opinion, will an introduction of ARNI reduce the need of device therapy in heart failure with reduced ejection fraction? Now, when you have the recommendations for implantable cardioverter defibrillator in patients with heart failure, these are recommended in patients to reduce the risk of sudden cardiac death or all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability and who are expected to survive for just less than 1 year. Now, more than 1 year with good functional status. So, an ICD is recommended in these individuals, and an ICD is also recommended for primary prevention to reduce the risk of cardiac death and all-cause mortality in patients with symptomatic heart failure, that is NYHA 2 or 3, and an LV ejection fraction of 35%, and who have had a more than 3 months period of optimal medical treatment, provided they are expected to survive for more than 1 year with a good functional class. So these are the indications for an ICD. Now, there is a gap in evidence. There's long-term data on tolerability and compliance of ARNI in real-world scenarios, which is still not available. But in my opinion, it is very important that if you can introduce ARNI for these patients, maybe they might prevent, you can prevent ventricular tachycardia to an extent of around 20% of these patients. So, implantable cardioverter defibrillators, yes, you can. These are patients who require these devices. You can start ARNI. It is not a substitute for ICD or CRT, definitely not. But having an ARNI on board can prevent sudden cardiac death to almost to the tune of 20% in patients with LV ejection fraction less than 35%. What are the contraindications for the use of ARNI and what are the cautions for the use? This is very important. Now, there are certain adverse effects of sacubitril valsartan which we all need to know. There's a 0.5% chance of angioedema. There's an 18% chance of hypotension. There's 3.3% chance of impaired renal function, 12% chance of hyperkalaemia, and 9% incidence of cough. So the risk of hyperkalaemia associated with use of MRAs was lower among those treated with ARNI than those treated with enalapril and MRA. So if you have ARNI and MRA on board, the chances of a patient having hyperkalaemia are less than having an ARNI and enalapril on board. These are also very important for you to understand. What are the contraindications and cautions when you are using ARNI? Contraindications: don't use ARNI within 36 hours of ACE inhibitor use. If there is a history of angioedema with ACE inhibitor or ARB, don't use ARNI. ARNI should not be used in pregnancy, lactation, severe hepatic impairment, that is child POC C, concomitant aliskiren use in patients with diabetes. You should not use ARNI. And also, if there is hypersensitivity which is known with ARB or ACE inhibitor in your patient, then don't use ARNI. And also, what are the cautions? Try to use it when you have mild to moderate eGFRs 30 to 59. Just be careful that it doesn't slip down to less than 30%. But in these patients, just be a little cautious. Hepatic impairment, so check your liver function test. If it's mild to moderate child POC A or child POC C or B, then we should be very cautious in using ARNI. If there's a patient with renal artery stenosis, again you should exercise caution. And systolic blood pressure less than 100, symptomatic, be very cautious. And if a patient is dehydrated, that is volume depleted, be very cautious about using ARNI. See that the patient is isovolemic when you start. What are the drug interactions? Now, ACE inhibitors is contraindicated because of the risk of serious angioedema, especially in African Americans. It doesn't appear in India, but then we have to be very careful. When you have aliskiren use, be very careful. Potassium sparing diuretics may lead to an increase in hyperkalaemia, especially in patients with renal impairment, diabetes, or hypoaldosteronism. NSAIDs, concomitant use, may increase the risk of renal impairment. Lithium, there's an increased risk of lithium toxicity, so just ensure that none of the other polypharma drugs on the paper are having lithium. And birth control pills, especially containing spironolactone, we should be cautious. So how do you manage hyperkalemia with ARNI? Strict low potassium diet, small doses of loop diuretics, you can introduce furosemide. K-bind can be used in emergency situations, and the old is gold, that is glucose insulin infusions in patients who are stubborn and resistant. So these are very, very important points. And what is the impact on the lives of patients in case you have discontinuation of ARNI? So if you find out that ARNI withdrawal can lead to repeated heart failure admissions, it can cause actually a patient who has had an improved ejection fraction, we go back to a reduced ejection fraction, and it can also increase the all-cause mortality if we discontinue ARNI. The other question which comes to mind is, should ARNI be discontinued once the LV ejection fraction improves? The so-called heart failure with recovered ejection fraction or heart failure with improved ejection fraction subset. In my opinion, no, don't withdraw ARNI, because if you have a guideline directed medical therapy, you should keep your ARNI on board and your beta blocker on board at least for a year or a year and a half after the patient has an improved ejection fraction or what we call recovered ejection fraction, because the incidence of the patient going into worsening heart failure or the patient going back to reduced ejection fraction status is very, very high. So it's very important for us to understand that keep that ARNI on board. If it's possible for a lifetime, go ahead with that patient. And what are the recommendations for heart failure with improved ejection fraction? In patients with heart failure with improved ejection fraction after treatment, guideline directed medical therapy should be continued to prevent the relapse of heart failure and left ventricular dysfunction even if the patient has become symptomatic. So the 2022 AHA and ACC Heart Failure Society guidelines clearly recommend that we have to continue your guideline directed medical treatment. So what are the pearls and what are the take home messages which I can give you today? ARNI is the molecule of the century and is indispensable. It is superior to ACE inhibitors in reducing cardiovascular death, heart failure hospitalization, and sudden cardiac death. Heart failure is a disease of epidemic proportions in India. ARNI improves the left ventricular ejection fraction in heart failure with reduced ejection fraction and reverses the adverse LV remodeling and improves the quality of life in our patients. ARNI should be initiated as early as possible in patients with acute decompensated heart failure and also in de novo heart failure. And here time is life, years. ARNI should be given for at least 3 to 6 months along with other foundational therapies for heart failure with reduced ejection fraction. LVEF should be reassessed with echo or cardiac MRI before any patient is considered for ICD or CRT. ARNI should be used in all patients with heart failure with preserved ejection fraction up to an EF of 56 to 60% along with SGLT2 inhibitors to reduce hospitalization for heart failure and also to improve the quality of life.